All right, good afternoon, all. We have a lot of questions, and one or two which we may not want to answer because they're personal, case-specific, and this just isn't an appropriate forum for discussing any one's personal case, but we'll try to get around that one way or another. We also have some leftover questions from this morning, and if time permits, we'll try to deal with those too. So let's get started. I have some specific questions for Dr. Odorizio. One, what are the possible side effects of PRT treatment? And two, what are the long-term hematologic effects?
So those are very good questions. In terms of the side effects, you have to keep a number that keeps coming back regardless of what center did the work originally, whether it was Paganelli in Milan or it was Mueller from Basel, Switzerland. The number stays the same with Y90 mostly, or lutetium, namely that you have to keep in the back of your mind that about 12% of all the patients treated have progressive disease. But you have to remember, these people were all progressing at the time they had it. These were not stable patients when all the first studies came out. Hematologically, the absolute number with lutetium recently given by Queckenboom from Rotterdam, and they're the pioneers of the lutetium-labeled PRRT, is about slightly less than 3%. And Eric can correct me if I'm wrong. And those are severe manifestations of it. We've seen several platelets that stay down and then come back up. We've seen white blood cells stay down and then come back up over 3 to 4 months. Hematologically, probably the lutetium, which is more like radioactive iodine-131 that we've used since 1930, has probably more effect on the marrow than does the yttrium-90. It's almost paradoxic because if you cut loose yttrium-90 in your bloodstream, it goes straight to the marrow. It can kill the marrow, but because it's attached to a peptide, it doesn't do it. So there's slight hematologic factors with the lutetium PRRT. We've seen very, very little with the yttrium. The kidney is the biggest problem with yttrium, and if it's done carefully, and we think lower amounts of radiation given slightly more often. Our study would show, and the protocol for yttrium-90 coming out in the end of August or September is going to have 3 fractions of therapy because we were most successful with that. Namely that we haven't seen the creatinines rise like after 12 years, like they've seen in Europe. So those are the minor ones. A little bit of radiation fatigue goes away in 2 weeks. Most often it's how do you feel clinically? It's now been shown at 2 different centers that a clinical response after even the first therapy bodes for stability. And that's a huge thing. They're finally tying the clinical response with midguts to outcome.
Thank you, Dr. Odorizio.
Tom, the hematologic toxicity question actually came from me, and the reason I was so I wanted to know the answer to that is because if there are any long-term hematologic effects, it certainly could alter the next steps in treatment for a patient, such as chemotherapy, et cetera. So bone marrow, long-term marrow toxicity is certainly a concern for me, and I understand your answer.
Very
absolutely.
valid. Very
Second,
valid.
I just want to comment on the term theranostics, which used several times, and I understand it's a new term that's been coined. However, that concept's been around for a while.
Yeah.
We've been using it for lymphomas with Rituxan and its radioactive analog. Right. So we've actually used that concept in the past. It's not a new concept.
Yeah.
It's new, certainly new for neuroendocrine tumors.
Yeah.
Not a new concept. And the third comment I want to make is that usually when I talk to my patients, I will tell them when they ask me about a lot of new diagnostic or therapeutic strategies that newer doesn't always mean better.
Better.
Sometimes you have to let it play out and see if it's better, but in the case of Tom's talk, it certainly is going to be newer is better, and we're just waiting for it to come to fruition so we can all get use out
Yes,
of it.
and I really
Thank you.
appreciate your comments, and that's exactly right. Theranostics, as you say, and Eric nods, it has been before. But when Baum announced it and made the Congress, it was like lightning, it just struck, and he took credit for it. So, but that's true. That's very true. I appreciate the comment.
And one important thing is I'm pretty sure Dr. Odorizio gave that first therapy in 1930, so, it's a historic figure.
I opened myself up for that.
Dr. Odorizio, I have a question, too, for you. Does it make any difference as to where the metastasis is? For example, will a soft tissue metastasis respond equally to a bony metastasis? And if there are lots of metastases in the skeleton, will that have an impact on the treatment in terms of marrow suppression?
So, that was a double one on the second question. The first question is, the point's well taken. Bone lesions, in the gallium, the Basel people are telling me that if the SUV max in the bone is above 3, it will predict for a good response in bone. But bone is tough versus soft tissue in general. So Dr. Warner's question then on the second part was, what was that again? The
Well,
second.
if you have a lot of bone metastases, does that make you at greater risk for bone marrow suppression?
Yes.
From the treatment?
Yes, and if you go back to the original, excellent, if you go back to the original work with what they called at that time Octreother, that was the Novartis product with Yttrium-90 that we did 12 years ago at the University of Iowa, they had a caveat. They said if the Octrea scan is showing intense uptake in the sternum, they recommended a bone marrow biopsy, which I did for probably 5 years on every patient because they did not know how much neuroendocrine tumors can infiltrate bone. And they accepted bone marrow infiltration up to 35% and said anything above that risks the problem of bone marrow suppression, pancytopenia. Because remember, you're going to have friendly kill. The agent's going to go in to kill the tumors, and on the way, it's going to hit normal marrow. So I was very careful early on and did many, and I still do. And the gallium now will be probably even more disclosive because it'll probably give you a handle whether there is a lot of marrow involvement. And those folks will get a biopsy and an aspirate. In other words, check their blood count, check their stem cell, their precursors for cellularity. So that's a great question. Yes.
Thank you. Here's another question that I think anyone of the panel should be able to answer. The question reads, for metastatic neuroendocrine tumor patient who is allergic to MRI contrast, what test is preferable every 3 months, CT scan or MRI with contrast? I would ask that questioner, why every 3 months? Because there are very few situations in which that frequent imaging is necessary. Also, it'd be very unusual to have allergy to the contrast, the gadolinium, which is the usual contrast for MRI, and not be allergic to the iodine-containing radiographic contrast used for CT scan. Does anyone else on the panel wish to comment?
Yeah, if I could just comment on that. I think it depends on what you're really trying to do with the MRI. So when you say you have a contrast, you should specify exactly what you have a contrast allergy to. There are 2 types. So there's gadolinium, which is a heavy metal, which is a contrast-free agent. And it can actually be used mostly for vascular appearances, okay? And then there's another liver-based contrast, which is specific for the liver. And so you don't need all the different kind of contrasts. And so if you're just looking in the liver, because that's really what MRI, I think personally, is really best for in our kind of typical abdominal neuroendocrine tumors, you might still be a candidate for it if they use the right type of contrast. So really, you have to specify. And it's the kind of thing where the only person who should know is actually the radiologist, and that's someone you very rarely talk to. So make sure your doctor talks to the radiologist to figure that out.
Thank you. This question states, how can you tell the difference between a primary and a metastatic lesion? And then an additional question is, when the Octrio scan is negative, that is, that doesn't light up, can you still be suitable for a gallium-68 scan?
Sure, I'll answer that. So, I think what we have to specify, I know Dr. Urisu mentioned this, is that the gallium-68 scan and the Octria scan are two fundamentally different tests. They may demonstrate the same biology, but they're based on two totally different types of physics, okay? So, basically you want to know one thing. You want to know whether or not it has somatostatin receptor, okay? The problem is that when you look at a Octria scan, it's kind of looking at a flashlight. You get kind of a diffuse image. Whereas if you look at the PET scan, it's like looking at a laser. So it's very concentrated, the image is very strong, and Dr. Odrisha he can show you over and over again. I can show you over again how many times you have a negative Octria scan with a positive PET scan. So if you have that, you just have to understand that, of course, if you have a negative Octria scan, you certainly can have a positive gallium scan. You can have a partially positive Octria scan and a strongly positive gallium scan. So it would be unusual for you to have a positive PET scan and a no. So no one have it. No, it's you always go from octreotide to PET.
Yeah. Which offers you that option, and you want to know if you have that option on the table, because I think the number for the SUV is quantitative for the gallium. And so with a quantitative number and your average SUVs, carefully done, is above a 3, you now become eligible for that therapy, whether it's now or sometimes down the road. But that buys you the option. And that, to me, is some of the most important things of what I do or we do, and that is that you have an option. Your next option, if this happens, you're ready to go to the next. You don't run out.
Thank you. Here's a question, rather long, and I'll abbreviate it. The questionnaire asks, relates that his mother had a carcinoid and eventually succumbed to it, and now he's worried about his children and other relatives, wants to know what can be done to protect them. Well, of course, this is asking a question really, is carcinoid hereditary? And the answer is, in only a very rare group, something like 4% of all cases, it is genetically determined and heritable. Usually, there's a good history, a strong history of other relatives that will have had carcinoid or some related neuroendocrine tumors. If we don't have such a history, doing the expensive genetic studies is not usually recommended, because most of the time it's not heritable. However, there are ongoing studies to find out more about this, but the usual surveillance type of examinations that one would have and complete history are sufficient. Does anybody on the panel want to add to that?
No, I would just say that as Dr. Labudi pointed up this morning, the familial, and Dr. Warner alluded, the familial syndromes, multiple endocrine neoplasia type 1 and type 2, do carry a carcinoid, a slightly higher carcinoid occurrence. And with MEN1, with a high gastrin situation sometimes, the gastric carcinoids, but just a slightly higher. But I agree with Dr. Warner completely. out of the 1,600 people that we follow, we have documented, I think, 5 families that have at least a first-degree relative with the carcinoid. It's usually a mother and a son or a father, and in one case, a daughter, but it doesn't, and then the rest are, where are they now? We don't know. So it's a very small percent.
Thank you. This question asks basically if the disease has been completely stable on Sandostatin LAR, octreotide, at a dose of 30 milligrams a month for 10 years, should the dose be increased because of possible increasing risk after 10 years, even in the absence of carcinoid syndrome, really does the effectiveness of the drug wear off?
So maybe I could start that. It's very interesting. If you're being an endo, you get to look at the acromegaly, the growth hormone secreting tumors. And I got beat up by that panel of experts because I thought there would be what they call insensitization or desensitization. But apparently with acromegaly tumors, they never become desensitized. There's a certain level that controls them, and they can stay on the same dose. Dr. Warner and I were talking earlier, clearly with the long-acting repeatable, which is what LAR is, there seems to be a sort of a desensitization wherein more is required, but you need to have symptoms of worsening, or you need to show CT scan evidence that there is a little bit larger tumor than there was before, I believe, before you start upping the dose, because more may not be better when it comes to the LAR. And the sub-Q, I don't remember ever seeing downregulation. We use a lot of pumps, the sub-Q infusion pump, for insulin. I have 95 people on the pump, and I must say, in only 2 or 3 did they think they needed more and more and more, but those are the only 2 or 3. Almost always they're controlled within a certain unit per hour, and they don't seem to become resistant. So maybe Eric has experience, or Dr. Gersten?
Yeah, in addition to downregulation, some of the problems that we can see with repeated use over long term of the LAR is injection site irritation and scarring, and there could be malabsorption from that as well.
Yeah.
Another question, a question related to this that was left over from the morning was what are some of the risks or versus benefits for long-term use of Sandostatin in patients that are asymptomatic. And so, if we treating disease and there is disease that is measurable, even though patients are symptomatic, we are continuing the Sandostatin. The long-term side effects we talked about before, which are gallbladder disease, abdominal bloating, but most importantly, hyperglycemia. So in patients that have already had the gallbladder removed, either at the time of surgery or the primary, or incidentally before that, gallbladder disease is usually not an issue, although sludge can occur. But long-term side effects, we have to monitor the glucose very closely. Patients will become hyperglycemic. They may develop diabetes, and it has to be monitored very closely.
Yeah.
Other than that, there's really, I don't know of any reason to discontinue.
Just one, and I'm going to scoop Dr. Warner. He's going to laugh at me. But at one time, I was a card-carrying AGA member in gastroenterology. But when it first came out, there was a study very clearly done with somatostatin and then with octreotide by a guy named Geer, G-Y-R. But you get a subclinical fat malabsorption, which tends to reverse over time. But when you develop a new type of diarrhea, which is odorous, floaty, oily, hard to flush, all the above, they're now escorting you to the filling station for the restroom. That is due to the fat malabsorption caused by Sandostatin. It inhibits prandial release of enzymes from the pancreas. And Dr. Warner, I'd like your thoughts on it, but it's an easy fix usually. You just take Creon, a digestive enzyme. I use a lot of papaya tablets. They come in gallon jugs in GNC, and they're about $10. And they got the enzymes. There's a kosher enzyme called Digest Gold. You can get it and that's a terrific one. It's made with, I think, vegetables, enzymes. And so if you start getting that kind of thing, and it's very upsetting. And what's your experience, Dr. Warner? Do you feel?
I agree completely. The inhibition of the pancreatic secretion of digestive enzymes which is very common with Sandostatin, results in fatty, floating, greasy stools, which also are frequent and very unusually foul-smelling and lots of gas. And that's usually corrected by taking pancreatic extract supplements, which are very easy to do with each meal, particularly foods that may be fatty or oily. And there are a number of such products available, and if one disagrees, then you can switch to another one. But that generally resolves that problem.
Yeah, exactly.
Thank you. The next question about Sandostatin, and this for Dr. Zaks. The question simply states, does Sandostatin protect you from carcinoid heart disease?
It seems to depend upon how successfully you are in getting your serotonin level down toward normal levels. And the rapidity of recurrent disease and the degree of recurrent disease seems to correlate with levels of serotonin.
I have Jerry for you.
Okay.
Do you want to answer the serotonin question first?
No, I was just going to say, when he was speaking, it's one of those things. Sandostatin should block the amine at the receptor, but, like it does other peptides that work on a receptor of a target cell. It just, in my experience, doesn't seem to do it when the levels start to get up around 1,000 or 800 or 900. You can't really change the serotonin unless you cytoreduce the tumor. That'll work. I just don't think Sando is as effective. I think the most exciting thing we have is the Lexicon 1606, because that's real. It does inhibit the synthesis. Dr. Gerstein alluded to it, and I think that's going to be the single best way to either cut it out, the tumor in the liver, or use that, and that may be an indication down the road for use with heart disease.
If I add one more thing, there's a very famous graph which shows the survival before 1988 and after 1988. And, basically, primary disease, lymph node disease didn't change, but the thing that did change a lot was actually distant metastases. And the reason the survival changed was because a lot of people did die of carcinoid heart disease, and, heart surgery was not as good. Nothing was quite as good. But after 1988, that survival curve really dropped a fair amount, and that's when Sandostatin was available.
Exactly right. It was introduced in we were second. Europe had it in 88, and in January of 89, it came in the United States. Yeah. Exactly
so
right.
It really did change things.
You're absolutely
Jerry,
right.
I have a quick question for you. It seemed from your talk that it was preferred to use the organic valve primarily because you didn't have to use Coumadin for anticoagulations, but that the mechanical valve worked better and lasted longer. So, or at least lasted longer if it didn't work better. The question I have for you, but you had to use Coumadin. So the question I have for you in the era now that we have alternatives to Coumadin for anticoagulation that do not need the monitoring of Coumadin or some of the side effects of Coumadin, have you used that in any of the metal valves, and will that increase the use of it?
None of those agents have been approved yet for mechanical valves. And the problem with those agents is that, unlike Coumadin, we can't reverse them quickly. And so, as of right now, Coumadin is really the only answer. But I must tell you that if you work closely with those who are doing procedures, we can help manage the bleeding risk. And I am really concluding, after looking at the results after the use of tissue valves, that maybe we should be shifting to the greater use of mechanical valves.
Yeah, what about low molecular weight? 2 shots a day?
Right, hasn't been approved yet
Yeah.
for mechanical valves.
Eric, I have a question for you. An article was written apparently in Radiology Today that suggested that imaging, PET imaging using regular PET CT or gallium-68 scanning could reduce unnecessary surgery. I haven't read that article, but
I wouldn't call it an article.
I think I know what the answer is, but I want to hear it from you.
I'll tell you about that. So whoever came up with that is very, very attuned. I'm very impressed. I think I gave it to my radiologist last week. This crowd. Okay. Anyway, so what it is the problem is, so like, you know, I think you know me pretty well at this point now. I'm very much a risk-benefit kind of guy, okay? And if it's too much risk and the benefit's too low, I don't think it's the right therapy for anybody, okay? So now you're talking about, okay, well, I want to get the primary out of your pancreas, okay? Small bowel is relatively low risk. Let's talk about pancreas, okay? Pancreas is a big operation, okay? Anywhere you do it, it's a big operation. It can be done safely nowadays compared to maybe 20 or 30 years ago, but it's a big operation. So now let's say you have a pancreas lesion that's not causing any problems. None, okay? And then your surgeon says, I can't find any other disease, so why don't we go ahead and just whack out half your pancreas, okay? Then the patient's like, let me just check. So they come down to me and they get a gallium scan, right? And the gallium scan shows a bunch of bony mets. Right. So now you're like, well, do you really need a Whipple for that? Do you need it today? You know, that pancreatic lesion may grow extremely slowly for years and years and years. So what we found was that about 20% of the time it changed the decision making. Sometimes it actually was what we call an intratherapeutic change, so within change. So for example, I'm doing surgery, there are more lesions that I would not have found. So I know, you know, the reason I like gallium so much is because it gives me a roadmap. Right? My job is to debulk you as close to 100% as I can. Even though 70% is okay, my job is to get you down to 100%. And, but it's a roadmap. So what do our colleagues do? Sometimes they take a little probe, right? You've heard about this, I'm sure. They take a little probe, they go around, they look for it. The probe is only this big. Okay, it's not easy to go around the whole abdomen looking for things, whereas the gallium scan, and Odo will confirm, it's just a big picture. So now that's an therapeutic change. Okay, so now what happens if you get an Octria scan, okay, and it shows just a lesion in the abdomen? And so you go there, you do surgery, you go whack it out, okay? And the patient says, I feel just terrible. I still feel terrible, okay? Then you get a gallium scan, and then they have a whole bunch of bone mets, like diffuse bony mets. And actually, that person really should have had systemic therapy, right? So the gallium scan has actually changed the decision-making process in multiple things because it affects the risk-benefit ratio. You see what I'm saying? So that's really what it is. And you can,
No, I absolutely agree, and that's just the setting, and that is especially the ones I think that are most important that we've seen are the pulmonary carcinoids, because you know they're deceptive. I do staging on those now, almost all of them, when I haven't known the patient for long and the primary's been removed, you suddenly start seeing these little tumorlets. They're called carcinoid tumorlets, you know, at the base of both lungs. And pulmonary people, or thoracic surgeons in general, seem to be a little more reticent to remove the primary if there's, you know, contralateral mets or I know Europe has a different view of it. I think they're more aggressive in taking the tumors out in the lung. But that in part may also influence the outcomes down the road of the stuff that we saw on that table that needs a lot of work, but it kind of shows that the pulmonary tumors have a little shorter time to progression and everything. But again, I totally agree with Eric. That it does impact tremendously at our tumor boards. You put that up, and all of a sudden, the game changes again, and I think it's all for the good.
Right, and I think what actually Odo and I have discovered is that you have to look at them. You have to look at them over and over and over and over again. Because I will hear many of my friends, and I definitely consider them friends, and they'll say, your scan is not worth it. I'm like, really? Well, how many have you seen? And that's really where we differ. And it is our job to kind of slowly introduce this technology and see if there's a new, a culture change with it. Because if it really does affect the way you live and it affects the therapy you give, then it is a wonderful, useful tool.
Thank you. We have a question here which is pertinent. The question reads, what other cancers should be looked for after carcinoid that has been diagnosed? What is the risk of getting another cancer? How often should you have a colonoscopy and an endoscopy after a diagnosis of carcinoid? Well, I'll answer that at least for the start. It is very definitely an important question. There's a much greater frequency of another type of cancer, particularly colon, lung, prostate, or breast, depending on whether it's male or a female, associated with carcinoid. In a study that we've done at our institution, which has been done elsewhere also a number of times, as many as 25% of all carcinoids at some time in their life will have had or will develop another cancer of another type. Therefore, colonoscopy, mammography, prostate examinations are all very important to be done on a regular, periodic basis in such patients, particularly even in a patient who's had known metastatic carcinoid. It's very easy for the doctor to say, oh, you got a new pain in your belly, the carcinoid must have regrown or spread.
Yeah.
It may be a totally different type of cancer.
Yes, and it's called secondary primary malignancy. And about 4 years ago, I reviewed the literature, which was international databases on if you had first discovery of a midgut. Out of the thousands and thousands they had a category of midgut tumors first, and then the secondary primary malignancy. And Dr. Warner is dead on. The colonic adeno-CAs are very high. Thyroid cancer was second. And I don't know if anybody cares to raise their hand as to whether they've had any thyroid problems detected who have that. But we've seen simultaneous thyroid neoplasia with the midguts. And the one that's more frightening lately to me is the pancreatic adeno-CAs in the setting of pancreatic neuroendocrine tumors within 3 to 4 years. And we've now seen 3. And it's the growth. You suddenly come in and everything is stable in the liver, and then all of a sudden there's a tumor in the pancreas that's growing, and and they've all 3 been pancreatic adeno-CAs. The other, maybe the people would agree or disagree. Alabama did a very interesting study. They go way back with acid secretion and looked at gastrin for years and years. And they had an abstract recently, I think it was in Nanets, where they had 5 people with pernicious anemia and high gastrin that they followed for 18 years. And 3 out of those 5 developed gastric CA.
Let me just comment on that. As the panel member, I guess, here that treats all different kinds of cancers, let me just say that you guys are not alone out there. And I tell all my cancer patients, whether it's colon cancer or breast cancer or lung cancer, just because you've unfortunately developed one kind of cancer. It does not mean you can't develop another one. And it's very, very common, specifically with breast cancer patients, to develop ovarian cancer or colon cancer, and it's a well-known syndrome and very common. So you guys are not alone out there. We're not trying to single out neuroendocrine tumor patients that can develop second primaries. This happens quite commonly in the oncology world. And you just have to be vigilant and listen to your doctors and still go through your routine cancer screening that you would have already regularly done anyway.
On a practical note, this means that colonoscopy should be done yearly, mammography should be done yearly, and prostate exam yearly. These are the major things, aside from a proper general examination.
But if I could just reframe that a little bit, or frame it a little bit, that's actually a good thing, if you think about it. That means that with neuroendocrine, that means you're living long enough to have other problems. People with pancreatic I know it sounds crazy, but people with pancreatic adenocarcinoma, they don't worry about anything else, right?
That's different, because at this point, the prognosis for pancreatic adenocarcinoma is so poor, and the disease is so aggressive and rapid that even if you have a concurrent malignancy of another type, the pancreatic adenocarcinoma is going to be fatal first.
That's the point.
Yep.
Another question, several of them. One, how important is it that an echocardiogram be read by somebody who is particularly familiar with carcinoid? And second question, is there some way of telling if the doctor or center that's treating you is experienced adequately in neuroendocrine tumors? My answer to that would be ask the doctor, ask the people who are treating you if they do this regularly, if they have other such patients, if they've gone to meetings in this nature, and if you get negative answers, then you're not in experienced hands.
My recommendation is to ask Mary Ann.
There are two issues here. One is that these are rare cancers. And the second is that most valvular heart disease involves the two valves in the left heart, which is under higher pressure and more commonly diseased. And so echocardiographers are used to looking at the aortic and mitral valves to the greatest extent. And very often, if you read the echo report, they say that the other valves were not visualized well, or they often don't comment much about the right heart valves. And so I think it's, in our carcinoid patients, it's extraordinarily important to have the echocardiographer focus the attention equally well on the right heart valves, and to be used to looking for subtle changes which to many echocardiographers would never even be mentioned, but are very important in terms of prognosis of progression of disease.
Thank you.
Yes.
This question asks, can you get cardiac valve fibrosis with low levels of serotonin or 5-HIAA? Is there a certain threshold above which you're at risk? Regarding the echoes, can you see changes on an echocardiogram before any symptoms?
I think it's a function of two things: how high the level is and how long the valves are exposed to that level. And so you will see curves of degree of disease if you graph it according to levels of serotonin levels, and also how long that exposure has been. I think that's really, those two factors, the level and the length of time of exposure.
There is also some unknown factor, because it's very poor correlation between the serotonin level and the presence or occurrence of valve disease. Nobody who has normal serotonin gets carcinoid valve disease, but not everybody with elevated values gets it either. And there's ample research to indicate there's something else involved, some disturbance in receptor or other type of fibroblastic growth factor involvement on the valves. That's still unclear, but there's enough suggestion there that that's being worked on and researched.
Yes. The other thing, too, remember the problem with fen-phen when it came out, the weight loss pill. And, Mayo was the first to describe anatomically the changes going on. But I think they ended up determining that fen-phen turns on serotonin from the fibers around the bowel. And, and like Dr. Werner said, it's independent sometimes of the level. But I think they did implicate serotonin is causing those valve changes. Is that right?
That's correct.
Yeah. So, I mean, it's a culprit. The other one that wasn't mentioned, that was talked about for some time, is substance P. And carcinoids do make substance P. It stands for substance pain. And it's a the GI folks have known it for a long time. It's a secretagogue that can cause diarrhea. I think part of the problem in the United States with substance P as a measurable peptide is that it's not a hormone in the classic sense. It's a neuromodulator. So it normally doesn't circulate in high levels. And I think the real issue is the level that they assign as a normal when you get it measured. And I think they're way too high on their normal level. Somebody probably ate a Big Mac and a normal person ended up with a serotonin level that was 1,700. And the real level in our blood is about 80 picograms. So I think it's gone to disuse, which I'm sorry to see, because I think it does set a certain, I think it can contribute to the heart disease with the serotonin. Certainly not the primary one. I think serotonin is. But that substance P has been talked about. Dr. Werner said bradykinin, and I think bradykinin is going to be another very important peptide to measure in the blood once we get it back.
Thank you. We have a number of questions regarding clinical trials and also PRRT. And some are very direct. For example, if PRRT has been around so long in Europe, why hasn't it been taken up in the United States until just now?
So
what's held it up?
Oh, okay. When I think of Europe, I think of my home country, Italy, and, the way things are done there. One of the biggest problems that it was when the FDA first looked at the information was they wanted dosimetry to be exactly like the material that they give therapeutically. That sounds a little mechanistic or whatever, but there's a thing. Y90 has no gamma radiation. It has some positrons, but no gamma. That means you can't do dosimetry. You can't check the kidney dose with the Y90 that you use for treatment. The FDA was very hard because they didn't have all the data that if it was going to come in the United States, they would have to use yttrium-86, which is very hard to make, very limited supply. And the surrogate is what we all have here is the Octria scan. The Octria scan is the surrogate for determining how much radiation dose there is to the kidney. And that's one of the reasons. The other, again, goes to the SOAP, S-O-P, the standard of procedure. They did not have that when they came to the FDA to bring it into the United States, and this is now 6 or 7 years ago. They had all the clinical information, but the FDA said, sorry, unless you have the SOP and it's all done the same way that everybody in the United States could do it, we're not going to accept your data. And that's just what they did with the gallium, and that's just what they did with the PRRT. And now we're backing up and trying to come back again into it. And And I credit Krenning for doing it, because he was the person behind the lutetium coming into the United States as a clinical study, a registration trial. They have a lot to gain from it. They want very much to have be able to do it for us in the United States.
But if I can make a comment on that, too. It's not that the FDA was against it. It's just that they wanted certain kind of criteria, right?
yeah.
So the thing to understand is that lutetium, which is a different kind of a drug, actually does have what Dr. Odorous said. It has dosimetry because it's technical, but it's a beta and a gamma emitter. So you can actually take pictures of lutetium. So that's why they're more open to it. The gallium thing, right? They needed a standard operating procedure. So we sat down and we just wrote, this is what we're going to do, pow, 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 pow. And then Iowa did a very similar thing. This is what we're going to do, pow, 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 and they just accepted it. So it's not that they're not. There are just certain rules you have to follow.
Very strict.
And we're working with them.
Yeah, absolutely. I think they're user-friendly there.
Maybe we can get through now the sequester's going through. It should be easier now.
Yeah, we'll get through. Get through.
Thank you. One questionnaire asks, how long will it take for the gallium-68 to become set up and used in hospitals in general in the United States? And how many places have the capability, even investigatively, at the present?
Eric's given me the nod. What I think Eric's Vanderbilt and Eric and ourselves and Dr. Sue are doing is, he mentioned there's a standard of procedure that we're giving to the American Society of Nuclear Medicine, their clinical trials. I don't believe it's ever going to come out, even with the Society of Nuclear Medicine overseeing the IND, as a FDA, it might, an FDA approved like Octreoscan. But between our centers, they're going to be able to modify it enough so that they would own the investigator new drug and be able to distribute it. But you have to remember, it's not a cheap thing to make. I mean, you can have a very fancy apparatus to do it, but you still come down to these generators that it's one of those things, if you don't use the gallium, you lose it, because it's made all the time from germanium, and it just keeps decaying. So that has a huge expense with it, and to make it at the different centers can cost anywhere from maybe $3,000 to, in our place, $4,600 to make one unit of it.
Tom and Eric, what's the bottom line here? When are our patients in New York going to be able to get this scan?
You can always get it.
Well,
There's a direct flight to Nashville.
Okay.
Every day.
You know what I'm talking about.
Yeah.
Is it ever going to be FDA approved?
Yes. Okay.
And
So
what's the time frame for that?
So I will. It's very complicated. Okay. And as with everything in life, as you bring things up and you show how neat it is, there are other people who are getting involved. So I actually honestly believe that this is actually relatively low-lying fruit. And I think within the next 4 or 5 years, I think actually, only because there's a lot of paperwork to do, and there are a lot of people involved, and it's very expensive. It's very expensive to get approved. I'm not per person, but to get approved. And but I think you will have it. But in the short term, if you need it, you can always come to us and do it. But we've already shared we shared R&D with Iowa, we've shared R&D with Los Angeles and Washington, and you guys have shared it with S&M, and I don't want this all to myself, right? I'm not interested in keeping this, nor is Odo, I think. We just want a tool for you guys to get better. So we push it as much as we can so that everyone can have it. It's just a matter of which institution wants to invest in it, which institution wants to do. I mean,
How about
it's those
Canada?
things.
How about Canada? Aren't there a few centers there that have
I think
doing it?
Sandy McEwen has it.
McEwen?
Yeah. I'm sorry, Dr. McEwen is out of Alberta.
Alberta.
I think he has.
Nuclear medicine.
Yeah, he's a nuclear medicine guy. But no, I don't think anyone else really has it.
Yeah.
Because they ship them to me.
The other center, we mentioned Dr. Abe Del Passant, who does have an IND for the lutetium, which he got from Dr. Krenning in Rotterdam. He's doing the same protocol that Eric and I are doing in the Lutathera. He now has his IND and he uses the gallium-68 for the same reason, to assess the value of what the therapy would be. The only other one I know that's up is the one in Indianapolis, where they do the bowel transplant, and they're using it for indication to determine whether a patient has no disease outside of the abdomen. And that's, I don't know if that's his only indication there or not. That's at the University of what, Indiana, in Indianapolis. So I think the most functional ones for the indication that we both have been talking about is Iowa and Vanderbilt. And on a regular basis, and it can be gotten, and like I said, our IND that's coming is for stable, known disease, and those two will be provided through the grant that Sue has, and the only cost would be insurance for an Octria scan, and that'll have, it'll have a limited time of availability. But that's how we keep doing it. We leapfrog the different trials.
Here's a question that asks some general points about clinical trials. The question is seeking to find out if there are general rules that apply in all clinical trials. It asks, do half the people have to have a placebo for a clinical trial? Of course, that would only, the answer is no, but you need to expand on that. And secondly, is a doctor not allowed to prescribe a drug which is being tested in a clinical trial? And again, that depends on the drug.
Right, so let me answer that question. Clinical trials are exactly as stated. It is a trial, it is a test, okay? There are different types of clinical trials in general. You may hear phase 1, phase 2, phase 3. Phase 1 is a safety trial, okay? And that's usually trying to find dose. Phase 2 kind of starts to get you into efficacy, and you may not need to have a placebo trial for, control. Phase 3 is really, you want to know if that drug works, okay? Because you want to know if it's really going to benefit people and how much it's going to benefit people. So you have to compare it to a placebo. This is for drugs, okay?
Not
This is
necessarily a placebo. It could also be a standard of
Oh,
care.
indeed, excuse me, yeah, standard of care, yeah, basically with and without, so basically is what the principle is. And so it may not be, so you will hear kind of this mixture of things. It's different for imaging, it's different for various things. So, but remember, the principle of a clinical trial, though, is to do no harm, right? Because you could give a drug that could be extremely poisonous to people. Right? So we minimize the number of people who are exposed to the danger in order to maximize, and try to maximize the amount of information we extract from it. So that's why. So there, in most of the kind of traditional trials that we do, like, Lexicon or Novartis, or any of these big companies, they want to have kind of this comparison to see what kind of effect they have. I mean, that was done with the PNETs and Afinitor and Sutent and things like that. Or ProMid, things like that. So that's really what it is. So you have to go onto clinicaltrials.gov, you have to read it carefully, you have to get a feeling for what they're doing, and then you have to ask the investigator what exactly is going on.
Let me just-
Sometimes, go ahead.
Let me just go on, expound on that a little bit. When I showed you guys the Radiant 3 trial, which was the Afinitor, the comparative arm was a placebo. That's because there was no standard of care for advanced PNET patients. Now, because in the United States we don't want to deprive patients of a standard of care, something that works, then some phase 3 trials do not have a placebo arm, they have a standard of care arm and then the experimental arm, okay? So it can vary. Also, it's not all cut and dry, as Eric said. It could be blurred. There are phase 2/3 trials,
Yes.
which sometimes blur the edges or trying to get a drug moving down the chain a little bit faster. So that can be blurred a little bit also. So, and as far as doctors prescribing drugs that are under investigation, again, it depends. As a practicing physician, we can prescribe off-label uses of drugs. So we can take a drug that's been FDA approved for one condition and prescribe it for another condition. That doesn't mean it's going to be covered by your insurance companies, but nevertheless, we have the right to prescribe it, and patients have the right to take it.
Everolimus, for example.
For example, everolimus in mid-gut
Mid-gut.
carcinoids, which is not FDA approved, but we use it, okay? If a drug has not been FDA approved and is under investigation, as a practicing physician, we cannot write that.
Yeah.
Okay, so there's a difference there.
Yeah.
There's also one last trial, if we're going to go into all the trials, there's a phase 4, which is a post-marketing trial.
Yeah, after
And
it's
that
out.
has to do with how the drug is used in the community setting.
Yeah, I just want to give you a little fun fact, because we happened to be at the FDA in 1989 when octreotide was approved for 2 indications, the diarrhea of carcinoid and the diarrhea of vasoactive intestinal peptide secretion, VIPoma. Yeah, VIPoma. So the approval was made on 177 folks with neuroendocrine tumor, studied and reported by 90 different physicians. That's exactly the information that was put together by Santos, now Novartis, when they submitted it to the FDA and was approved. And it's just what Dr. Gerstein said, so we're used to seeing, they're used to seeing in oncology, and they do it better than anybody, the phases that are required for drug approval. But this is one of those kind because of the rarity and every doc in the country that was doing neuroendocrine tumors wanted a bottle or a box of this stuff. And that's exactly how it was approved. Not as an orphan drug. It came out as a regular approved drug.
I'd like to add a comment for the benefit of patients. There is no industry agreed upon definition of experimental.
Yes.
And so there is a person who's an expert on this issue, that's Lori Todd. Some of you know of her. And I would recommend that you Google Lori Todd. She's called the Insurance Warrior. And she is readily available. I hear from her about once a month. And what she pointed out is that she knows how to find out if the insurance companies have paid for even one patient to have a form of therapy. And if so, she will use that in appealing a denial. And it's very important to be aware of the fact that you can appeal denials, and only a small percentage of patients really do this, but she is highly successful in doing that.
And I don't know how Eric works how they work it at Vanderbilt, but the way our IND is set up as a consent form, because it is a clinical study for the gallium, what I call the immediate indication for gallium. And once the patient reads the contract, there's about 5 lines that say, I agree that if insurance does not cover, I will pay. Once the patient says that, we have a pre-authorization group in the cancer center that goes right at the insurance company for approval. And yes, peer-to-peer has worked several times for me for indication for the gallium. But that's why it's not a standard level of care, it's a clinical study. And I agree with the word experimental. It raises the hair and what few I have in the
We don't
head.
use the word experimental.
You
ever.
don't.
We don't experiment on
You
people.
don't. You don't.
We use the word investigation.
Investigation.
These drugs are investigational drugs. They're being investigated for certain conditions, but we don't experiment on people.
And when you ask about a consent or a clinical study, and there's an IRB called an Institutional Review Board that looks at the benefit versus the risk. And if the risk outweighs the benefit, they won't approve it. You don't even see it until it's been looked at, and they figure that because, given the disease, that the risk, the benefit far outweighs the risk. That's how they look at it. It's a very, very good process in the United States, I would say.
Thank you. Here's a very, very direct question. Of the 14 PRRT trial centers in the U.S., and they're referring to Lutathera, the
Lutathera.
trial in New York City is at New York Presbyterian Hospital. Why not at Mount Sinai or Montefiore? Will New York City area doctors be referring patients to New York Presbyterian? to do this, to enter this trial.
Listen, yeah, did you write it?
I can answer that.
Yeah, you can go ahead.
Because I represent the group at Mount Sinai, and we sought to be involved in the trial. And when it was awarded to another hospital, I queried the company to find out why, what was going on, because we probably see more, or not probably, almost certainly see more patients with carcinoid and other neuroendocrine tumors than any other institution here. And the company told me that they received a report that there would be more patients available at New York Presbyterian Hospital. In addition, they inspect the facilities, and they liked the laboratories there and other facilities better. At least that's all they would tell me.
Yeah,
So that's where the situation is.
And we're very happy. We're very happy. We've opened the study, which means it's all been approved. Our first patient will be treated April the 16th, hopefully with lutetium, and not the other arm is the 60 milligrams of Sandoz, which I think is a very hard comparator. I think it's a great challenge for the PRRT against 60 milligrams. There's no precedent reported about the 60 milligram dose per month. That's a lot of protein substance in either gluteal muscle, either buttock. But at the same time, they've made it very strict. I think the issue is going to be the number of visits, and I think it would be great if you had more along here, if Labudi might have it and Dr. Warner, because the number of visits that you have to make in the first 24 weeks is physically grueling for this study. And it's not to put anybody off, it's just to say that it's a very closely monitored study. It's very safe. From my experience with PRNT, the 120 that we did, the benefit far outweighs any risk to the PRNT. The kidney is one exception, but if it's done carefully, we, like I said, we'll show soon, maybe 5 months, but I think our creatinines, the kidney function with Y90 was a lot less than was experienced in Basel, Switzerland. And the amino acids, the trick is the amino acids. It's mechanical, but the reason they come back and say, I vomited, I was sick as a pup, is because the amount of amino acid protein that they had to put in the vein initially was very high rate, and people got very sick from all that protein going into their vein. They've cut it down, and they're giving it longer for almost 4 hours, and it protects the kidney. And everybody's going to be doing it the same way. And because we gave less, we went with Novartis's protocol, and we're going to do it again, the original one. They used fractionations of three fractions over 9 weeks each. The European group, when they used Y90, determined the safety to the kidney and then divided the total dose in two and gave one dose, and then 9 weeks later gave the other. I think that's what it is. Lutetium's a whole different beast, as Eric suggested, because it's a softer beta energy. So it doesn't have, even though the residency time, the time it sits in the kidney is longer, it's a softer energy, and it doesn't seem to have the kidney damage effects. I mean, Basel, Switzerland reported with probably 100 of my patients, 10% kidney damage with the Yttrium 90. And that was off the top of the map. It should have never happened.
Sorry to yell that out.
No, it was okay. It's no.
One.
But
You're
yeah,
among friends now.
yeah, yeah. No, but that was it. But it's not going to happen in the United States.
One last question before our time is up, very short. The questioner asks about the risk of prostate cancer in a young adult male, age 40, who had the carcinoid tumor. And the answer is, if there's a family history, then that person is definitely at risk and needs to be very periodically screened. If there's no family history, one examination and then repeat exams every couple of years should be sufficient. Does anybody on the panel have anything else to say in that
I don't
regard?
think so.
Thank you very much.